Good evening, everyone. Welcome to tonight's webinar. Tonight, we are going to talk about an exciting and innovative therapy with Dan Kaufmann, who leads the Danielle Foundation's Migraine Management Program. I'm Elizabeth Henry Wire. I am the Executive Director of the Danielle Foundation. Our mission is to empower those living with migraine through advocacy, education, and support. Before we begin, we do have a couple of reminders. Dan, if you don't mind going to the next slide, thank you. The content of this webinar is intended only for educational purposes. It's important to consult your own healthcare provider to address your specific needs and circumstances. Tonight, I'm excited to be joined by Dan Kaufmann, who leads our migraine management program. He is going to introduce us to emotional awareness and expression therapy and how it can help chronic pain and migraine. Dan, please take it away.
Okay, well, thank you very much, Elizabeth, and good evening to everybody that are listening to us. Again, I'm always excited and always humbled when I'm coming to the Danielle Byron Henry Migraine Foundation and to present in whatever shape or form. Tonight, I wanted to talk about pretty much the result of my last research about a novel intervention. It's called EAET, Emotional Awareness and Expression Therapy. But I wanted to expand a little bit more before going to talk about EAT, to talk about what is it that we have out there in the arsenal of psychological treatments. But before we actually begin, there are several things that are very important that I wanted to share, or kind of like to have a baseline so people would understand where I'm coming from, especially if people are listening to us and they've never attended our courses. Because we have a lot of people who come to our courses, and we already know how much the uh, people living with migraine are suffering from a lot of stigma, a lot of beside the fact that migraine is debilitating, they're so poorly misunderstood. And so I am always wondering before I'm giving a talk to people living with migraine, if some people might be asking themselves, oh, great, another expert is going to tell me that it's all in my head. So I just want to make sure that we kind of like create some sort of an understanding, because the things that are in the slide is what I believe in. First, migraine is a real disorder and it has an identified physiology. I've researched that in the lab with preclinical models. I'm seeing that with people. It is a real phenomenon, and people with living with migraine have debilitating migraine attacks that cause significant distress. This is not something that is easy or not something that is easy to overcome. Most importantly, because we hear it a lot from people who come into our courses, migraine is not a mental disorder, and people living with migraine are definitely not crazy. The reason I'm saying that, again, we hear that a lot. People have been mistreated, misunderstood, put down. People coming to us and other people who don't understand migraine say, oh, you're probably crazy. Oh, it's all in your head, and all sorts of things. So I want to make sure that before we start talking about what we're going to talk about today, that we're just clarifying where we're coming from. We know that migraine symptoms are real. They're not imaginary. And most importantly, people living with migraine are not to blame. There's nothing people can do. With that, I also want to say that my research is focused on emotional triggers for migraine. And hopefully, by the end of this webinar, I hope to convince the people who are listening to us that those are worthy of attention. And I would also want to say that some of the concepts that we're going to talk about might be new, maybe they're not, but there might be new, There might be causing some, I don't know, reservation or some resistance, which is fine. It's normal. I'm reaching out to all of you. Please try to keep an open mind with everything we're going to talk about. What I'm what I'm going to be talking about, from all I know, is based in research and evidence. It's not a personal opinion. So I'm just portraying things as we understand them. And yes, we can always change our minds or change our understanding with more evidence that is going to come. So with that dramatic opening, I would like to talk about the what we're going to talk about today. Before we talk about any treatment, I just want to talk very generally about what is pain and what is migraine, very much in general, because that would help us understand a little bit better of what are the treatments that are now recommended, what are they trying to do, and how is EAET might be different. We're going to talk about behavioral interventions for migraine, the ones that are currently recommended by the American Headache Society and other societies. There's a lot, but we're going to focus on the three main interventions that are offered, which is cognitive behavioral therapy, mindfulness, and biofeedback. And we're going to discuss the issues that we foresee with the current behavioral approaches for migraine and how we think that emotional awareness and expression therapy might be different from other intervention. Of course, we're going to summarize. So I would like to start by saying that I'm sure people have seen that on the internet and the news. If we look at the titles, let's just kind of look at the titles. The War on Chronic Pain, Fighting Pain with Veterans, A Demon in the Brain. What is it like living with chronic pain? How do we call medications that are supposed to reduce pain, painkillers? So it's like from all of this, it's like we're trying to get it's like the idea that pain is this horrible enemy and we're going to fight it. We have a war. We're going to kill it. We're going to kick it. And that makes sense because pain is debilitating. It is unpleasant. And of course, we want to get rid of it. What I'm suggesting, just for the purpose of this webinar, let's take a little backward stance and let's look at pain from a different lens that might help us understand how to work with it, because that's the essence of the treatment that we're doing. With that in mind, I'm inviting you to just kind of sit backwards and let's just, before we hate pain and want to get rid of pain, which is normal, let's think a little bit more. What is pain? We know that pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. That's a definition by the International Association for the Study of Pain. We know that pain is something that evolution created. Why evolution created pain? Because it's supposed to protect us from real danger or from potential danger. That's why we have that. And the whole point is because pain is so unpleasant, that's what makes it achieve its job. I always hear that when I give presentations and I talk about these people that have a genetic mutation and they can't feel pain. And especially people that are living with all sorts of chronic pain condition, the first thing I hear is, oh my God, I'm so envious. Oh, I want to have that too. But the fact is that people that can't experience pain, they don't survive for long because the whole point of the system that's supposed to warn them from danger doesn't work. So, in essence, if we just look at an evolutionary perspective for pain, we're thinking that pain is actually supposed to be a friend. It's supposed to warn us. It's supposed to warn us from danger for something that is happening. Every pain also has a physical component and an emotional component. And this is our understanding of pain. And it exists as a response to a threat. Now, the idea, what I would like you to get from it is that pain does have a physical component, but it also has an emotional component because when we experience pain, we also attribute meaning to it. We describe pain in emotional language. It can cause us to feel distraught or depressed or anxious. So there is going to be an emotional component to it. But what I would like you to get from it is that pain originally exists as a response to danger. We're not talking about migraine yet. We're just kind of going a little slower on this. And so when we talk about the signaling of how pain comes about, pain never starts with pain. Every pain is a result of a danger signal. If we just look at this figure here on the slide, we have an example of like a pin that is pricked on the finger. We have those specialized nerve cells. They're called nociceptors. You don't have to remember that. But the information, if I get pricked by a pin, goes all the way from my finger to the spinal cord and to the thalamus. And from there, it goes to the brain to many, many, many centers. And from there, a story is being created in a fraction of a second. All these different brain areas are activated, and it's like they're asking questions. What do we know about this pain? What is the meaning of this pain? Have I experienced that in the past? How dangerous is that? And in a fraction of a second, eventually the brain comes up with an answer. Am I in danger or am I not in danger? If I'm in danger, the brain will produce pain. It's a real pain, but it's a response of a danger signal. If there's no danger, then there's not going to be pain. So, in essence, what we're talking about is that if the brain determines that we're in danger, it will produce a pain signal. Otherwise, it might not, and there's a lot of literature around that I'm not going to bore you with. Now, let's talk a little bit about chronic pain. And again, we're talking about pain right now. The longer the brain is flooded with those information about danger, the more it becomes more sensitive. So it's like the threshold for pain becomes reduced, and stimulus that are not supposed to be painful, like combing our hair, putting our hair on a pillow, putting on glasses, becomes painful. It's not imaginary, it is real because the pain threshold is reduced. Those symptoms are called allodynia or hyperalgesia. And the more the brain is flooded with this danger signal, the more it just becomes more sensitive. And it's like the brain is just trying to get adjusted to this flood of information, becoming much, much more sensitive to pain. If you want to use an analogy, it's like we have a symphony that all plays all sorts of tunes, I don't know, Bach, Mozart, whatever. But all of a sudden, when the brain is flooded, it can only play one tune, the pain tune. And it's like the brain is hijacked by those messages of pain. When that occurs, it's like the brain feels that it's constantly in danger. It's bombarded by this danger signals. When that occurs, then everything else that can amplify danger can increase pain. What can amplify danger? All sorts of emotional stimuli, like negative thoughts, like this will never go away, my life is hopeless, migraine will never go away, no one believes me, and so forth and so on, which are legitimate. But all of those stressors can amplify pain. And I want to say another thing about that, and that's the fact that when we talk about the danger signal, remember that I mentioned that pain has a physical and an emotional component. When the danger signal is physical, like a pinprick or stabbing my toe or so forth and so on, that's relatively easy to identify. We see a cut, we have a blood test, if there's inflammation, we can see markers, CT, MRI, so forth and so on. What I suspect and this is what we're doing in our research, is that when the danger signals are emotional, we don't have CT, we don't have MRI, we can't detect them. That doesn't mean that they don't exist. We hypothesize that those emotional danger signals might contribute to pain as well. This is why we're focused also on the emotional aspect of migraine, not just the physical one, because I'm sure the people who are listening have already seen doctors, neurologists, taking medication, so forth and so on, and keep doing that because that is part of dealing with migraine. That said, there is a connection between emotions, stress, and migraine. Emotional stress has been reported as a migraine trigger in several clinic studies. We also know that there is a bidirectional connection between anxiety disorders and migraine. We know that one exacerbates the other. When I'm going to have a migraine that is unanticipatory, like I don't know when it's going to happen, then of course I'm going to have anticipatory anxiety. How is it going to be? How bad is it going to be? Am I going to be able to cope with that? Of course, if I'm more anxious, then guess what? We're increasing our danger signal, might be experiencing more migraine. One exacerbates the other. But there's another thing that is important, and that we also know, and that's not my work, there's a lot of work in the literature, that migraine is associated with the occurrence of adverse life experiences. We know that there's a higher prevalence of adverse life experiences in migraine, and there's a correlation between the two. Now, when we have migraine on those other comorbid disorders, and of course, it's going to be much more difficult to manage because if I'm going to have depression and migraine, I'm probably not going to want to take medication. It's going to be much harder to deal with. So, dealing with the emotional aspect is important. I want to pause for just a second, just because I know in the migrant community, there's all sorts of opinions. And I know that there's some people that rightly think that there's no connection between stress and migraine. Migraine is the real phenomena. I want to emphasize something. Stress is a real phenomena, and migraine is a real phenomena. It doesn't mean that all of the people who are listening to me, stress is necessarily the trigger for migraine. I didn't say that. However, there is a chance that because emotional triggers are harder to identify, it might be that it would be important to focus on identifying them so we can have a whole picture of looking at the physical, doctors, medication, blood tests, whatever, and the emotional. That's all we're trying to do because we believe that the emotional aspect of migraine is as important as the physical one. That is why, because of this connection, I'm sure you've already seen there's a lot of interventions. There are psychological intervention to treat migraine. Mindfulness, progressive muscle relaxation, cognitive behavioral therapy. There's a lot. So before we're going to talk about the EAET, I just want to give a bit of an overview of what is out there, the main things that are out there. How are they planning to actually address migraine? What are the pros and what are the cons, and so forth and so on. And so, just in general, these are the recommended behavioral interventions for migraine. Again, they're not substitute for medical. They're not supposed to replace medical intervention. But we strongly believe that the emotional component of migraine is as important, which is why research has indicated that some of those interventions are helpful. What are those interventions? Number one that is mostly reported is cognitive behavioral therapy. And I know I'm heard it in the past. I'm sure that some of the people who are listening to us, when I say cognitive behavioral therapy, they just want to turn off their computer and go. Please stay. Because I'm going to say something about cognitive behavioral therapy, and I understand how cognitive behavioral therapy can be misrepresented. Cognitive behavioral therapy is short-term, it's short-term oriented psychotherapy, and it's a set of strategies to help us identify and challenge inner beliefs, inner thoughts, and identify and correct maladaptive behaviors. Now, I know that when I say negative self-talk, it automatically brings us to, oh, here it goes again. People think that migraine is all in my head. It is not. I'm going to talk a little bit more about what cognitive behavioral therapy does. Relaxation exercises are also recommended just because of the correlation between increased stress and migraine. So there's a range of skills to reduce arousal, decrease stress, from progressive muscle relaxation, diaphragmatic breathing, guided imagery. We teach a lot of those in our courses. Hypnosis is written here as a description. That is something I have to say personally. I'm a little offended, to say the least, just because as a hypnotherapist, hypnosis is not just relaxation. There's a lot under that umbrella, but maybe for a different webinar. Mindfulness is something that relatively in the last decade or two, a lot of people have introduced mindfulness and researched mindfulness. It's a focused awareness on the present moment, letting go of what we can change. It helps decrease stress, focus away from pain. So that is considered an intervention for migraine. Biofeedback, using sensors to measure physiological parameters in real time and help us have a better control of our stress response. And of course, healthy lifestyle. We all need healthy lifestyle, healthy sleep, eating habits, hydration, nutrition. We all know that there's some food that might trigger migraine, so all of those are important. I want to go a little further into each one and kind of explain a little bit more what these are, how and what they offer for people with migraine, and what might be some of the issues with them. I want to start with cognitive behavioral therapy. Again, we just heard it a lot, and I know that cognitive behavioral therapy might be a dirty word for some people living with migraine, but just bear with me for just a second. Maybe not, but maybe I can convince people otherwise. The proponent of CBT is Aaron Beck, seen here in the upper picture. He passed away, and today the torch is being carried by his daughter, Judith Beck. And the thing is with cognitive behavioral therapy, as its name implies, is that individuals have automatic thoughts. A lot of times we're not aware of that. And a lot of those thoughts are resulting from internal beliefs or internal schemas. And the important thing is those thoughts don't exist in vacuum. They cause us to behave or to feel all sorts of things. And so when we're not monitoring those thoughts, they might cause us to engage in maladaptive behavior or just feel bad. We've heard it a lot also from people living with migraine, the thought of, no one believes me, my doctor doesn't believe me, my life is hopeless, I will never, this migraine will never go away. I know what my friends think, they're so tired of me because they thought of my migraine. All of those thoughts we heard a lot. Those have an effect. I mean, when we keep thinking those, I don't think anybody can be happy. So monitoring those thoughts and learning ways to better cope with them is what CBT is one of the things CBT does. Also, maladaptive behaviors, like if I overtake medication because I'm so anxious of when my next migraine attack is going to come, so I'm just going to take medication just in case, and maybe I'll increase the dose. We know that this happens too. That can actually cause some issues. So by using cognitive behavioral techniques, we can correct a lot of those maladaptive thoughts and patterns of behavior. And also importantly, cognitive behavioral therapy has a lot of evidence to document its effectiveness for many, many disorders. Usually, what is done in the intervention is usually the client needs to observe. They encourage to observe and document their thoughts, their behaviors about pain and about other things that they do in life that might be connected to their symptoms. So first is observation. A lot of things that can be used in cognitive behavioral therapy is skills training, like stress management technique, like assertiveness training, interpersonal issues training. There's all sorts of skills that people can benefit from learning. Cognitive structuring is one of the main claim of fames of cognitive behavioral therapy because once the clients identify their maladaptive thoughts, they can learn how to challenge them. We provide some cognitive behavioral therapy skills in our courses because we teach people what to do when they actually do have that thought. My life is hopeless. My migraine is horrible, and that is true. How do we deal with that? Because it's so painful to live like that. So there are ways to challenge those thoughts and think something differently just so we can feel better. Psychoeducation, providing accurate information about migraine, about pain, about all sorts of things, again, another thing that cognitive behavioral therapy does, and behavioral modifications that when we know that when we have a problematic behavior, like I can't sleep, or I overuse pain medication, I don't know what to do, cognitive behavioral therapy can provide a lot of skills to modify those. So, is it actually effective? Now that let's assume I convinced you how great cognitive behavioral therapy is. Is it actually effective for migraine? So, researchers indicate there's a lot of research for cognitive behavioral therapy in migraine. There's a lot of discrepancies, but because of the methodologies that people are using, overall, cognitive behavioral therapy is efficacious in reducing psychological stress, depression, anxiety, self-efficacy, mood, and so forth and so on, and increase quality of life. In terms of general pain, not migraine, general pain, cognitive behavioral therapy has been shown to reduce pain in general. Some studies have shown that cognitive behavioral therapy is effective in reducing in reducing the number of migraines. However, I will have to say that the effect size was relatively small, and usually there's a lot more compelling evidence that cognitive behavioral therapy is important and useful for all of those other things that we just mentioned, the depression and anxiety, which are related to migraine and are important. So cognitive behavioral therapy is useful for that. The evidence is much more compelling for increasing quality of life, less so in migraine frequency of severity, but there are studies that indicate that this intervention can reduce migraine frequency and severity. I put the last bullet point again. I already mentioned that because I know that we heard a lot of people that say, oh, another therapist is going to go and is going to focus on my thinking. And it's just reinforced all this trauma, actually. It was traumatic when people keep telling people living with migraine that it's all in their head when it's not true. So the assumption that cognitive behavioral therapy reinforces the idea that migraine is just in your head and so forth, it's actually not true. There might be things in CBT that might be helpful. I'm not trying to convince anybody to do or not. I'm just trying to show you that cognitive behavioral therapy has all sorts of things, and we also want to maybe give it credit when credit is due and make sure we're not just throwing the baby with the dirty water. In terms of mindfulness, there's a lot of different definitions. Everybody talking about mindfulness. Generally, what we do in mindfulness is focus on the present moment in a non-judgmental way, and we just release and just accept whatever happens. The practice, once it's done correctly, and once people practice that, people have reported a very much increase in sense of well-being, reducing depression, and so forth and so on. There's a lot of different things that can be done under the umbrella of mindfulness. Mostly, the one that was mostly researched is mindfulness-based stress reduction, which is an 8-week program. Body scan, which is a practice designed to increase awareness of our body. Another practice, which is called soften, soothe, and allow, which is a treatment, that's intervention that helps us just sit with maladaptive emotions, maladaptive feelings, And rain meditation was kind of similar. It's again just sitting with when I have a very, very bad feeling or bad migraine or I am very, very depressed. It's just to have the ability to just sit with the emotions, not judge them, not trying to fight them, and just accept them as they are. It sounds crazy. It sounds like, whoa, how can I accept my depression? But actually, the more we practice, people get better at it, and it helps to just accept things versus fight with them. Because sometimes when we fight things, they just increase. So that's the purpose of mindfulness practices. Mindfulness have been recommended, have been used in pain and in migraine specifically. What we have learned about mindfulness is that, again, it's very much efficacious in improving psychological symptoms, mood, distress, general well-being. In terms of is mindfulness really effective to reduce migraines? There is a bit of this, there is actually a lot of discrepancy. The literature is kind of undecided. There were some studies indicating that it does. There are others that say that it doesn't. Some of the studies have a relatively small sample size, meaning they tested it on not a lot of people. So at this point, it is hard for me to say migraine has the potential to reduce your migraine. However, having the ability to better work with our emotions, our thought is, in my opinion, also important. And I'm just providing you with this information so that you will decide if this is right for you or not. And lastly, biofeedback, which is another recommended intervention, comes from the territory of applied psychophysiology. It uses the knowledge about our interrelationship between the mind and the body. We're using it to educate ourselves on what our body is doing when we think about all sorts of things. Biofeedback is a specific intervention from applied psychophysiology that we're showing people in real time what their bodies are doing and how their bodies might be changing as a result of thinking of something, telling ourselves, oh, my life is hopeless, or memories, and so forth and so on. The important the importance of this is because instead of a therapist telling you, oh, I think you look relaxed, or oh, I think you look stressed, the person through their own learning can just see their body in real time and learn how to use different techniques to change their body. And it actually is pretty nice. I mean, I personally love biofeedback, but I think that the importance is that people learn from themselves, not from what, the therapist or someone tells them to do. And it can also help reinforce building resourceful states. So people learn how to better control their bodies, which, especially because a lot of people with migraine feel that there's no control. The fact that all of a sudden I can have some control of my body is very important, I found, with a lot of people that living with migraine. What are we doing in biofeedback? There's all sorts of intervention. Muscle tension is one of them. We use sensors, usually electrodes, usually on the trapezius or somewhere on the face. And we're able to identify if there are tensed muscles. A lot of people have migraine attacks because they're not aware that they're tensing the muscles, maybe their shoulder muscles or the neck muscles. And so this intervention helps people identify how it feels when your muscles are tense, because a lot of time we're not aware, and how to relax the muscles at will. It's a learning paradigm. Heart rate variability uses a specific kind of breathing to affect the heart. It's called resonant breathing. There is some indication that this kind of breathing has been effective for people living with migraine. That's what we also teach that in the foundation. But heart rate variability, it's a specific kind of breathing that is supposed to reduce the autonomic activity or the autonomic activation. Because migraine is an autonomic phenomena, I don't want to get too much into it, but that's another modality in biofeedback that might be helpful for migraine. Skin temperature originally identified as a migraine prevention in 1973. People learn how to change their peripheral skin temperature at will, and it assumably helps with migraine. Again, there is a physiological explanation. I don't want to get too much into the detail, but skin temperature, learning how to change or how to increase skin temperature was shown to be effective in migraine. Evidence does indicate that biofeedback has a level 4, meaning it is efficacious for migraine, and it's a level 5, which is efficacious and specific for tension type headaches. In general, we know that overall biofeedback is considered efficacious, specifically for tension type headaches, can be used with other modalities, but it can also be very cost effective, meaning it's less cost effective, meaning it sometimes can be very expensive to engage in biofeedback treatment. I will tell, and this is only my own view, it's not based on studies, but my own view, biofeedback has been nice and helpful, but I admit that I was very limited in how much I was able to help patient only by using biofeedback. And other people also recommend to combine biofeedback with other approaches. So we've talked about all those modalities. What is the problem? They seem to be doing okay. They seem to have some efficacy. What we suspect is that those currently psychological approaches, they have good, but their efficacy is relatively limited. All of those interventions are focused on this whole notion that migraine is stressful, stress can induce migraines, so let's decrease stress. And they focus specifically on the symptom, on the pain, on the stress, and they're doing a good job at it. Something that occurred to me, to us, to several of my colleagues, because we know, and that's work that has been done, that there is a correlation between adverse life experiences and migraine, none of those interventions actually address that. And all of those approaches are pretty much talking about let's cope, let's help you cope with a migraine, but much less has been discussed on let's help you reduce the migraine, which can be dangerous because, I don't know if I can reduce anybody's migraine, so I'm definitely not going to say it. But when that is the main assumption, then there is no chance to more improvement. So we were asking the question, because those interventions don't address the emotional outcomes that result from adverse life events, would it be beneficial if we found a treatment that actually can address the ramification of adverse life events? And would that help people with migraine? We didn't know. So we decided to test it out. And I actually decided to test it out. And so a couple of years ago, I came across with EAET, Emotional Awareness and Expression Therapy. And EAET was based on a lot of literature that talked about, it was a lot of research that connected between emotional processes and chronic pain in general. They didn't talk about migraine, but the correlation between the two was very much known. Again, as we talked, that's why we talked in the beginning that pain has an emotional and a physical component, because the correlation is not just by chance. There is something to say about emotional trigger. So Dr. Howard Schubiner, Dr. Mark Lumley, two dear friends and colleagues of mine, they created EAET and they tested out in different chronic pain conditions, and it showed efficacy. It showed efficacy. It was actually better than some of the approaches that I mentioned. And the whole point was that they focused on dealing with the ramification of adverse life experiences. The idea is that when we experience adverse life events, trauma, abuse, or even things that are not as dramatic, but still are traumatic, what we call big T's or little t's, Those don't operate in vacuum, especially when that occurs in a developmentally sensitive periods, like when we're kids. Our brain is just developing, and when we experience tremendous amount of stress, it might predispose the system towards something. And that is something we know from research. It may cause an overactivation of autonomic phenomena, central dysregulation, all sorts of things that might predispose people to some disorders. And right now, we're still not talking about migraine. But migraine, because of the correlation, was interesting to me specifically. So as I learned about EAT, I started researching that, and I'm like, wait a minute, this sounds like something that I might want to test in migraine because I talked to a lot of people and they talked about their trauma. What are the principles of EAT? Some of them we've already discussed. First is that pain is only generated by the brain. Again, this is not to say it's all in your head. It is to say that the only organ, physiological organ that we have in our body that is able to create pain, not just amplify it, is the brain, and the brain is in the head. So the idea is to educate, just like I've done in this webinar, that pain is actually a danger signal. It's a danger signal of physiological and emotional or psychosocial danger cue. We also believe under this core principles of EAT that when we had difficult emotional experiences in our lives, no one wants to deal with that. No one wants to revisit that. It causes us to be fearful, avoidant. It stays somewhere inside. We carry that out, even if we don't consciously think about it in every day. Those experiences are still inside us, and they can cause an increase in this danger signal, emotional danger signal. When we are experiencing things like in developmentally challenging periods, then usually those stay with us throughout life. And unless we really deal with that, look at it, and really resolve them, we might be carrying a huge emotional baggage. So, what we're doing in EAT, we learn to experience and express all sorts of emotions in an adaptive manner in the hope that once these are resolved, the danger signal can go down and people can feel better. How do we do that? We can do that privately using imagery. We can do that in writing all sorts of, we call it emotional writing. We can do that safely in the sessions that we do EAT when we actually help people review those unidentified emotions that we're carrying from the past that we haven't resolved. We can also do that in relationships, like assertiveness, like intimacy, all those things that we're afraid to experience or express. We learn to actually stop avoiding. I'll give you an example. We all know that in personal relationships, we might, like if someone tells me something that is offensive to me, I'm not saying, oh, well, I'm not going to say anything. I don't want to hurt their feelings. So here I am stuck with a hurt, and I'm not letting it out. That hurt is not going away. It's still inside me. Learning to express what I feel in relationships is part of the thing that we do in EAT. And lastly, we keep tracking changes in pain, emphasizing how emotional changes can cause pain reduction. We help the people who do EAT to recognize how might their emotional trigger affect their migraine. Now, I want to emphasize something. That doesn't mean that EAT works for everybody. That doesn't mean that all of you have emotional triggers. And we don't know. What we do know is that with the people that we worked with, we were able to identify a lot of emotional triggers that even they didn't know, which was helpful to them in reducing their migraine. In essence, what we're doing in EAT is the whole point of recognizing that when we go through life, We have daily hassles, relationship conflicts, secrets we're carrying with ourselves that we never told anybody, private conflicts, emotional trauma. We carry all sorts of things. Life is not easy for anybody. All those events that happen, they're not just forgotten. They created some emotions in us. Usually, those emotions are really tough to deal with. So, normally, naturally, we don't want to deal with them. No one does. I don't think I even want to. But eventually, when we avoid those emotions, we hypothesize that it can increase pain, symptoms, and create brain changes. When we learn to experience those emotions, to revisit those avoided emotions, avoided stressors, avoided conflicts that we're carrying, when we're able to experience and express them, it can cause reduction in pain, normalization. And so, what we learn in EAT is to stop avoiding and start experiencing emotions. The protocol is manualized. It's usually in the research that we've done is 8 session protocol. It's done in groups. We've delivered that via Zoom to small groups. It's very small. It's not like the resources course. It's maximum 5 people just because of the intensity of the treatment. It's 2 hours per session. Each session includes lectures, discussion, but mostly exercises that we help people identify avoided emotions, and we're giving them homework to keep working and practicing. Exercises, what are some exercises? Some of them can include what we call an empty chair. What does that mean? Is that let's assume that just as an assumption, I was a kid and I was really badly treated by my mom, really badly for many, many years. And I've never told her that because I was a kid. And then I grew up and I'm like, "Oh, she did the best she could. And it's okay. And she didn't mean it," which might be true. But going back to it, I was a kid and I experienced something hard. I experienced pain, I experienced insult, and I needed love. I needed my mom to love me. All of those things are staying in there. Using exercise of an empty chair in session, we're imagining, let's say for this example, we're imagining mom on a chair and me telling her everything that I've ever wanted to tell and never dared to tell. Like, mom, I needed love. Mom, whatever that may be. Emptying all those things that I'm carrying out. That's some of the exercises that we use, just as an example. Broadly, what the intervention includes is number one, to identify how life stressors connected to symptoms and core conditions, like what might be triggering my migraine emotionally. We're talking about the emotional defenses symptoms triangle. We're talking about how when I have an emotion and I avoid it, how does that related to my symptoms? We start talking about defenses and talking about avoidances and how do I recognize those and how do I stop using them? And most importantly, we start to learn adaptively to experience and express emotions, all emotions. That includes anger. That includes guilt or compassion or sadness or intimacy or whatever that may be, that sometimes it's hard for us because of what we've gone through in life. So, learning to experience and express emotions is one of the main things we're doing. We're talking about relationship conflicts and how to use healthy communication, talking about a little bit about forgiveness of self and others, learning how to be more adaptive during relationships, and it's also we're learning to become more assertive and learn how to express my needs, my emotions when I'm dealing with other people. That is pretty much kind of an overview very broadly of what this intervention includes. Now, again, I want to emphasize maybe some of the people who are listening to us say, I don't think my life is fine. I didn't have any trauma. I don't think that fits. And that's fine. We're not we're not trying to convince anybody. We're trying to present information. But I also want to encourage people that when we talk about adverse life experiences, we're not necessarily talking about the things that, we read in the newspaper, like a horrible death or sometimes even a misunderstanding that was really hurtful to me can be interpreted as a danger. And I just want to revisit this. Why we're doing this? Again, because a lot of times physical symptoms can be easily identified. Emotional triggers, we don't have, at least I don't know of a tool that I can identify. So we found that by identifying emotional triggers and helping people relieve them, we found that we actually got a pretty good response in terms of migraine. And so I just want to show you briefly, this is from my study that we've just completed. There's a lot of information. I mean, I'm not going to share everything. I just want to show you that if we look here in this upper graph, this is the effect of what EAET did only for people with migraine. And this is the number of migraine days in a month. People who got EAET after treatment showed a really significant reduction in number of migraine, which is what we wanted to see. Those who just waited those 8 weeks, we didn't see anything at all. Those in this group, and I'm not showing this in here, but in this group, those who agreed to come back and get EAE treatment also showed reduction in migraine days. Quality of life, we also evaluate. We evaluated many other stuff, but I don't want to burden you. We measure quality of life. Quality of life significantly increased after EAT. People that didn't receive EAT, we didn't see anything. Those who waited and got EAT afterwards, again, showed an increase in quality of life. I just want to show you real data in here just to show you that I'm not trying to make this as a miracle. Not everybody got relief. It wasn't working on everybody. But you can see in this table the number of migraine days originally, like before treatment and after treatment. Those with the those with the dark blue, you can see that it's significant from 17 to 2, 17 to 7, 16 to 6, 23 to 9. But we have others that were not as dramatic, 20 to 14, 13 to 7, and we also had people that didn't benefit at all. So again, it's a new intervention. We're still learning about it. But in this study that we just completed, only on 34 people, we hope that EAT can provide a new intervention that might be effective specifically for people living with migraine. I want to show you that this is what people have said, that they felt much better, they want to continue doing the work, they allowed it to see that you have improvement in my migraine. Some of it was maybe subtle. I wanted to show you everything we got, not just all the hoo-has and all the great results. The last meeting, I was so excited about the progress I had. I felt assertive, I felt confident. My hadiths have been significantly better. So we have all sorts of people. Some of them got significant, but most of the people as a group showed reduction in migraine, increase in quality of life, and we were happy to see that. So with that in mind, just want to summarize and just say that we started talking about pain as an evolutionary conserved perspective because we're used to treat pain as the enemy, which makes sense. But I'm encouraging people to look at it in a little different perspective because it is a danger signal predominantly when we have a physical danger signal or when we have an emotional danger signal, which is much more harder to find. If the brain thinks or if the information that is collected is being analyzed as if the person is in danger, it will produce a pain symptom or a migraine symptom. And it's like in chronic pain, the brain is stuck. We know that migraine is a chronic disorder that affects so many people and how it's so debilitating and traumatic to have migraine. We know that anxiety and mood disorders live hand in hand with migraine, which is why there's a lot of recommended intervention like cognitive behavioral, mindfulness, relaxation, biofeedback, and so forth and so on. We believe that those recommended intervention, well, it might be great for some things, but we feel that not addressing adverse life experiences is one of the main things that we found that needs to be addressed. And when we tested emotional awareness and expression therapy in migraine, so far, and it's just the beginning, we're seeing some promising results. Now, I want to be my own devil's advocate and just say this is relatively new. It was a pilot study. It was only 34 people. We don't know much more than we do know. Like, who is it going to work on? Why? I mean, there's a lot of research we need to do. But I'm hoping, because I decided to dedicate my life to help people with migraine, I'm hoping to continue pushing and researching that forward. Maybe, hopefully, it could be helpful for anybody who is listening to this webinar. I would like to conclude, first of all, to say thank you for everybody that listened to me. I hope I didn't aggravate anybody. I hope I didn't say anything that might have been misinterpreted. That was not my intention. I learn from every person with migraine. I keep learning every day, and I hope to learn more so I can learn to help people more. This is my information, my telephone, my email, if anybody wants to ask questions. We are the Danielle Byron Henry Migraine Foundation, as Elizabeth mentioned, we are offering those tools as part of the foundation. The email is here, the website is here. Please reach out. We are offering EAET as part of the foundation as well. I'm only one person, so bear with me, but we are hoping to offer this to as many people as we can. And without further ado, that concludes my talk.